I would now request Dr. Nimmi Mulwani to introduce our next presenter. Please, ma'am.
Thank you so much. For our next talk, I would like to invite Dr. Anish Chandarana, sir. He is MD/DM Cardiology, FACC Cardiology, and he works at SIMS Hospital as an interventional cardiologist. His talk for today is Prevent Organ Damage with Good Hypertension Control. Over to you, sir.
Good morning, ladies and gentlemen. I personally thank you all for sharing your valuable time to listen to this presentation. Now, we all know that high blood pressure has been existing since long, and we as scientists have learned how to treat that. We have also kept on changing the thresholds and targets for the blood pressure control. One thing which is very important, why do we evaluate a patient of hypertension, or why do we treat a patient of hypertension? The idea is patients should not progress to various end organ damage and end organ failure. So when you see a patient of high blood pressure, it is critically important to pick up whether a patient has got any end organ or target organ damage. And if they are there, then the severity of treatment or intensity of treatment or line of treatment can be different. So in this presentation, I'm going to discuss for 13 to 40 minutes about what are the target organ damage and how to control them. I don't have any personal conflict of interest as far as this talk is concerned. So what are my ideas to share and discuss? Number one, what is end organ damage or target organ damage, and now more scientifically known as hypertension-mediated organ damage? What are the factors causing them? Is it only the blood pressure, or there are some additional factors which cause them? Once patient has got target organ damage or end organ damage, does it mean patient has got high risk of heart attack and stroke? Number four, which is very important, once a patient has got some kind of target organ damage, does it mean that we have to treat the patient differently? Does it mean that we have to treat the patient more intensively? Is it the blood pressure control or a specific drug which is more important? Say for patient has got left ventricular hypertrophy. Now, all the drugs would work similarly, or there are specific drugs which would work better and prevent this further organ damage. Which is the first drug of choice? Is it RAS inhibitions, calcium channel blockers, diuretics, beta blockers? Is it a single drug, or it should be in combination? A very important point. We all know that we have to treat the blood pressure quite well if a patient has got established organ damage, but how fast you have to get the patient under control and how well you have to keep the patient under control, that is also very important as far as target organ damage is concerned. And in last, we'll discuss about risk-based BP reduction strategy. Now, we all know that untreated or uncontrolled hypertension leads to a variety of end organ damage. Initially, it leads to left ventricular hypertrophy, hypertensive retinopathy, hypertensive nephrosclerosis, or vascular dementia. And ultimately, all this microvascular disease progress and leads to macrovascular disease also in terms of stroke, heart attack, kidney failure, heart failure, etc. So we all know that untreated and uncontrolled hypertension is a serious, serious issue. Now, we also know a very important fact. Once a patient has got one or more risk factors like blood pressure, diabetes, dyslipidemia, smoking, the first thing which is to happen in the body is vascular dysfunction or endothelial dysfunction. Once there is endothelial dysfunction or vascular dysfunction, it leads to vascular disease. And then once the vascular disease sets in, it leads to a variety of tissue injuries, say, for example, myocardial infarction, stroke, and ultimately an organ will fail and a person will die. So on most of the occasions, once there is a risk factors like blood pressure or diabetes, a patient or many patients will pass through this, what is called as cardiovascular continuum. Yes, at any stage, patient has a risk of sudden cardiac death, but most of the patients will travel through this journey. This gives an important chance that if a patient has got high blood pressure and some kind of end organ damage, if you treat blood pressure well, if you add on various treatments and modalities, there is a chance that patient will not progress further to the tissue injury and end organ failure. So defending and deciding end organ damage is so important in the treatment of blood pressure. The question number one, is it only the intensity and chronicity of blood pressure which is responsible for target organ damage? The answer is yes, intensity and chronicity of BP, which is called as blood pressure load or hemodynamic load to the system, is a very important predictor of target organ damage. This is one important study in which they compared the people with refractory hypertension against the people with control group. And what was found? Prevalence of various target organ damage like left ventricular hypertrophy, carotid plaques, hypertensive retinopathy is much more in the people who have got refractory hypertension. So more the blood pressure, longer the blood pressure, poorer the control of blood pressure, there is more risk of target organ damage, no doubt. But that is not the only predictor. There are predictors beyond that. If you go only for the chronicity and intensity of blood pressure, it is a good predictor, but quite inadequate to define on end organ damage. In your clinical practice, you might have seen many patients, two patients who have got the same blood pressure, 160, 160, almost same profile, but one would have established target organ damage and one might not. So what are the factors beyond that? And science has understood it is the activation of sympathetic nervous system, activation of renin, angiotensin, aldosterone system, certain metabolic and inflammatory factors, all they come to play a role to produce end organ damage in addition to blood pressure. Say for one example, if you talk about high salt consumption, irrespective of blood pressure, it is leading to left ventricular hypertrophy, proteinuria, and various vascular changes. And another example is obesity. So high salt consumption and obesity are two factors which work through sympathetic nervous system and RAS to create premature or earlier end organ damage in people with even mild blood pressure. So it's very important. And that's why this concept that it's not only the blood pressure, but add-on issues or markers which can lead to end organ damage creates a base that different drugs working through different mechanisms can have different benefit in people to prevent end organ damage. The question number two, once a patient has got end organ damage, does it mean that patient has got high risk of future ischemic disease or ischemic events? The answer is yes. Look at here. Irrespective of the blood pressure, whether it is less than 140 systolic or between 140 to 160 or more than 160, once a patient has got microproteinuria, his or her risk of development of ischemic heart disease in next 10 years is almost 2 to 3-fold higher. So once a patient has got some kind of target organ damage, his or her risk of CV event is high. And similar is the story with left ventricular hypertrophy. Look at any age, whether a patient is younger or senior citizen or elderly. If patient has got LVH on ECG, his or her risk of future CV event is much higher. So this clearly means presence of target organ damage in a patient with high blood pressure does lead to high risk of CV event. The question number third, then does it mean that if a patient has got some kind of target organ damage, LVH, proteinuria, increased carotid intima media thickness, etc., then does it mean that we have to treat the patient more aggressively? The answer is now the guidelines have come with generalized low targets for everyone. Whether you have got established end organ damage or you don't have, but now most of the guidelines of the world have gone to BP target of lower and lower values. If you look to the latest American College of Cardiology guideline, which was released in 2017, they have made a BP target of less than 130 systolic and less than 80 diastolic for almost all people, irrespective of the age, irrespective of the target organ damage. And if you go to the European Society of Cardiology guidelines, they have made the age category. Those who are relatively younger, less than 65 years of age, they have asked to chase to a target of less than 130/80. While those who are senior citizens, that's where European Society says, be a little careful, chase them to first to less than 140. If you believe there are no adverse effect, if they are tolerating that blood pressure well, you can think of less than 130. But none of the guidelines at the present, which are quite famous across the globe, do say that if patient has got some kind of end organ damage, go more stronger. But generally, the values which are now asked to chase and target is less than 130/80. A very important point, when you see a patient of high blood pressure with established target organ damage, as I talk to you, you will target a blood pressure of less than 130/80 slowly. But very important point that you have to reach the target latest by 3 to 6 months. This is a very important data obtained from value trial, which compared basically ARB versus calcium channel blockers as a treatment. But this is not the comparison. This is about the people who achieved blood pressure target within first 6 months. So those who were brought to less than 140/90 in within 6 months, their chance of having various cardiac events, fatal or non-fatal, stroke, death, myocardial infarction, that was all less as compared to people who didn't achieve control in first 6 months. So it's very important. When you see a patient of high blood pressure, your plan and strategy has to be get the blood pressure to control, either by lifestyle or by one medicine, two medicines, or three medicines, latest by 3 to 6 months, because it makes a lot of difference if you do not control blood pressure within that period of time. Not only it is important that you have to reach to the targets quite quickly, but it is also important that you have to stick to those targets for most of the time. We have seen in our practice that many patients do achieve target of less than 130/80, but then because of various reasons, inertia of patient, inertia of doctor, they lose to the follow-up, they lose the motivation to get treated, and then their blood pressure remains high. Again, they go to the doctors and blood pressure gets controlled. So this is a wonderful data. What happens to cardiovascular endpoints or heart failure? If your blood pressure is controlled for, say, for example, 6 months, well out of 12 months, but rest 6 months, your blood pressure is not well controlled, your risk of cardiovascular events, say, for example, is 1. Then if your blood pressure is controlled for only 3 months out of 12 months, your risk of cardiovascular event is quite higher. While if your blood pressure is well controlled for 9 to 12 months, your risk of CVD is less. What does it mean? Out of 12 months or out of year, your patient's blood pressure should be well controlled, less than 130/80 for most of the times. Once in a while, if patient has gone up, that's okay. But for most of the times, blood pressure should be well controlled. Now, very important point, we know that there are various drugs for the treatment of blood pressure and they have got good data. If you look about RAS inhibitions, calcium channel blockers, diuretics, they all have got strong data that they reduce death, MI, stroke, heart failure, and kidney failure. Even beta blocker has been good for the people who have got LV systolic dysfunction or post-MI. But people who are having no established atherosclerotic cardiovascular disease, the data of beta blocker is less, and same is with the alpha blocker. Now we know that we need to prevent MI, stroke, heart failure, and death in patients who got hypertension. But this is quite long. To prevent death, MI, and stroke, you have to go for 20, 30 years in patients who develop blood pressure at a young age. So what is more important is you need to have drugs which not only prevent MI, stroke, and death, but you should be able to find out, do the drugs lead to reduction or regression in end organ damage? And that's why in last 10 to 15 years, many trials have been designed which look at the surrogate endpoints rather than the hard endpoints. That whether a drug has capacity to regress LVH, whether a drug has capacity to improve endothelial function, whether a drug has capacity to reduce the progression of intima media thickness, proteinuria, new onset of diabetes, or new onset of atrial fibrillation. Because all these surrogate endpoints, when they appear in the journey of blood pressure of a patient, then they all suggest a very bad future risk. That's where we have got different drugs. And if you know, and we all know that based on trial, RAS inhibitions is one thing which scores highest. And that's why, say, when you want to treat a patient who has got blood pressure with end organ damage, or when you want to prevent development of end organ damage, the first point is you have to have a robust blood pressure control. You have to reach the target as early as possible. You have to get the treatment so effective that blood pressure remains less than 130/80 for most of the time. Then you need almost a combination of treatment. A single drug may not be sufficient in more than 50% of patients because of various reasons. So RAS inhibitions makes the background of combination therapy, and then you can add on various drugs. Now, which drug can be the best addition to RAS inhibitions? And there is a wonderful trial which was released quite way back, SCOT BP trial. That's where they treated the patients with either combination of RAS, that is ACE inhibitors plus CCB, or age-old tested, time-tested combination of beta blocker plus diuretic. Just cutting the story short, the combination of ACE inhibitors plus CCB had all the benefits in terms of heart attack, stroke, death, etc. So since then, beta blocker plus diuretic is a combination which has been pushed to number 2, while ACE inhibitors plus CCB has been considered a very logical and quite effective and preventive combination. Many times we know that ACE inhibitions or RAS inhibitions make a good combination with diuretic. They are quite synergistic. So a question remains whether it is RAS inhibition plus CCB or RAS inhibition plus diuretic, which is a better combination. Again, ACCOMPLISH was a trial which tested the combination from beginning. It was not a step-cut treatment. It was like a good combination of drugs to be given from beginning. And what was found is whether you combine ACE inhibition with CCB or whether you combine ACE inhibitions with diuretic, both of them were quite effective in reducing blood pressure and getting the blood pressure to target within first 3 months. But what was found is this combination, that is ACE inhibition plus CCB, had little edge over ACE inhibition plus diuretic in terms of prevention of various cardiovascular events. So if somebody asks me, as far as patients who are for primary prevention, those who do not have established atherosclerotic cardiovascular disease or LV dysfunction, what is the best treatment to prevent future events as far as blood pressure is concerned? The answer is reasonably clear. It has to be ACE inhibition plus CCB. And that's why most of the societies of the world believe that you have to select RAS inhibitions for the younger people. In people who are more than 55, they have got low renin status. That's where CCB or thiazide type of diuretic is a first choice. And then subsequently, in most of the patients, you have to make a combination of 2 or 3 drugs. And a single pill combination of 2 or 3 drugs has scored over because of the compliance. Now, before we end, there are 2 important things which I would like to make your attention to. We all know that as far as story of LDL cholesterol is concerned, when you reduce 40 milligram of LDL cholesterol, that is 1 millimole reduction in LDL cholesterol, gives you 22% benefit in major adverse cardiovascular event. So that was the same question which this meta-analysis answered. When we reduce 10 millimeter of systolic blood pressure, do we give cardiovascular benefit, and what is the cardiovascular benefit? So those patients on whom we reduce 10 millimeter of mercury systolic blood pressure, the major adverse cardiovascular events are reduced by 20%. And a wonderful another question which was answered by this meta-analysis, does it depend on the baseline blood pressure? The answer was no. Even if your baseline blood pressure is more than 160, if you bring 10 millimeter systolic BP down, you get 20% MACE benefit. If your baseline blood pressure is 150, reduce it by 10 millimeter of mercury, you get another 20% benefit. And this trial or meta-analysis could find it out that even if your baseline blood pressure is 130 or less, if you reduce systolic BP by 10 millimeter of mercury, you reduce major adverse cardiovascular event by 20%. So this meta-analysis has opened a new era, that a patient whose blood pressure may not be high to be called as hypertensive. A blood pressure may be of 130, 132. But then if you reduce systolic BP by 10 millimeter of mercury, patient can get benefit 20%. So those high-risk people who have got blood pressure of 130, they have got high cardiovascular risk because of various reasons. Say, for example, smoking, diabetes, and organ damage. In those patients, even if they are not termed as hypertensive, but if their BP is 130 also, you reduce 10 millimeter systolic BP and you can give 20% benefit. So ladies and gentlemen, coming to sort of carry home message from this presentation, number one, presence of one or more target organ damage does signify high risk in patients with hypertension. So once you've got a TOD, you have to be more careful. LVH, proteinuria, EGFR, and ankle brachial index are important TOD to be measured, to be monitored regularly in all patients of hypertension. Robust BP control goes a long way to revert target organ damage and prevent major adverse events. So chase 130/80 in most of the patients unless there are adverse effects. 130/80 is the figure which we have to keep in mind. RAS blockade, either ACE inhibitors or ARB, are the cornerstone of treatment, and you can combine calcium channel blocker and or diuretic them as a single pill, which can help a lot. BP lowering by 10 millimeter of mercury does reduce major adverse cardiovascular event by 20%, even if your baseline BP is 130. So this has opened a door for people who do not fall into the definition of hypertension, but if they've got high severe risk, reduce their BP by 10 and they can get tremendous cardiovascular benefit. Thank you very much for your kind attention, and we'll be open to your questions when the question answer session is declared by the chairperson. Thank you very much.
Thank you, Dr. Anish Chandarana.